Okay, so it's now sharp 4 p.m. in Dubai time and 3 p.m. Saudi Arabia time. And welcome from all around the globe. We are here for this webinar. I am Zain Al-Mahari again. I am the leader of IVPN Personalized Medicine, but I'm giving the lead today for Dr. Sharmeen Roy. Dr. Sharmeen is the Chief Strategy and Science Officer at DOSME, where she leads the integration of model-informed precision dosing into clinical practice to improve patient care. She has more than 20 years of experience in pediatric clinical pharmacy, clinical research, pharmacogenomics, and healthcare leadership. Dr. Royce has worked at leading institutions, including Texas Children's Hospitals, the University of Chicago Medical Center, the Miami Center Institute, and held senior leadership roles at Pipeline RX, supporting over 500 hospitals through innovative clinical solutions. She is a board certified in pharmacotherapy. Dr. Roy is passionate about advancing precision medicine and making technology adoption seamless for clinicians, ensuring equitable, high-quality care for all patients. So I would like to give you the stage, Dr. Sharmeen, to introduce our dear guest. And welcome. Thank you both for accepting taking this, being with us today. And I hope it will be like a fruitful webinar for all of our attendees and for us for sure. Thank you.
Thank you, Zaina. I appreciate everybody joining this morning. Well, sorry, I'm in the US, so it's morning for me. And I know we're truly global as we have multiple time zones. So hope you're having a good day wherever you are throughout your day. So thank you so much. And for attending. It's my honor to introduce Dr. Zaid Ibrahim. He's a consultant oncology pharmacist and a Churchill Fellow with over 38 years of experience working as a senior clinical care pharmacist and pharmacogeneticist at the Department of Health in Western Australia. Dr. Ibrahim graduated with high distinct honors. He's a faculty of pharmacy at Alexandria University in Egypt in 1986 and achieved his postgraduate diploma in pharmacy in 1988. He's gained his oncology board certification in the US in 2009 and his master's degree in clinical pharmacy from Curtin University in 2012. Zayad has been recognized as a consultant advanced pharmacy practitioner since 2021 and ANSCAP in hematology oncology in 2024. Dr. Ziad is very passionate about improving patient care and outcomes through practicing precision personalized medicine in oncology. He's currently a member of the Molecular Tumor Board of Western Australia, where tailoring treatment to individual patients' NGS map mutations is being practiced. He's also a senior research fellow at University of Western Australia, leading a pharmacogenomics research project to personalize cancer treatment with high-dose methotrexate. The methotrexate in seriously sick kids, or MISC, study as part of his PhD. And after this webinar, Dr. Zayad, I'd love to hear more about that project, but he is an aspiring leader of pharmacy profession in Western Australia and Australia, as he is aspiring to bring new frontier of practicing precision personalized medicine to improving patients' quality of life and outcomes while reducing length of hospital stay and rate of readmission. He has visited top precision oncology and medical centers across the world through his Churchill Fellowship to refine his skills and knowledge, ensuring Australian healthcare is at the forefront of precision medicine practice, especially in cancer care. So thank you, Dr. Zayad, for joining us. We're very, very excited and looking forward to your talk, and I'll turn it over to you and we can get started. Thank you.
Thank you very much. Thanks. That's so much, I guess, lovely words from you, Sharmeen, and nice meeting you. It's lovely to have you as the coordinator for this webinar. So I'm really keen and happy to share my experience with everyone who's dialing in today to or attend this webinar. So not sure if you want to start by me talking or do you want to ask questions, or I can go through a quick presentation, sharing a couple of cases, and then we move on to the situation in Australia, where we at with application of pharmacogenomics, especially in cancer care.
I think that sounds good. We will save the questions till the end. If the audience has questions, please submit them in the chat, and then we will go through them at the end of the presentation. So I think that sounds like a good plan.
Fantastic. I'm not sure if I can share the screen.
Let's see.
Yeah, sure. You can, Dr. Ziad. Just share your screen. It's from down the share button.
Should be on the bottom menu.
Okay. Just let me check. It's just because we we no longer actually operate with Zoom in Australia, so I have to just log in through the I guess the browser rather than an application. So I'm not sure whether it's actually allow me to do everything that I need to do. Let me just check. View encryption. I can't see any option for me to share the screen.
You're not seeing any button?
So at the bottom, there is participants, there's a chat, there's reaction. Oh, here it is. I found it. Okay. All right.
Yeah.
I'll share that one. Can you see it now?
Yes, perfect.
Okay. All right. So I'm just going to move it actually. Oops. All right. So today I'm just going to talk about the situation of or implementation of pharmacogenomics in Australia in brief, and focus on cancer care and the impact that might lead to. So we just quickly will dive in. This is actually in Sharm el-Sheikh. I was enjoying my diving certificate at the time. So the aim of this webinar, I guess, to introduce you to Australian healthcare. So a little bit of a quick overview of what Australian healthcare look like, and then the pharmacogenomics in Australia, and where is the cancer care pharmacogenomics getting applied. Also, we can talk about different perception and tools of precision medicine, but also highlight the current situation and research that we are undertaking. So I have two cases that I'm going to actually swift through them, because I've written them for a different presentation or lecture. But basically, this patient is 52 years old, and she was diagnosed with advanced breast cancer, and she chose through a couple of treatments, and then came in February this year with brain metastases. So we opted to give her some sestizumab govitecan, and we sent for UGT1A1, although the guidelines does not actually recommend or required UGT1A1. It's suggested but not recommended. So we didn't get the UGT1 in time, and end up actually the patient has opted to have a full dose before her UGT1A1 test came back, but she was actually a homozygote for allele star 28, and despite the fact she received one single dose of sestizimab govitecan at a full dose, and that led to severe neutropenia or febrile neutropenia, led to overwhelming sepsis, and she passed away a few weeks later. So she only had one dose of sestizimab govitecan at full dose, unfortunately. So rather than me going through this, I'm just going to swift through the sestizimab govitecan. Obviously, it's similar to irinotecan, and govitecan is actually the SN38, the active form of irinotecan, which means it's much readily available. So that perhaps lead us to talk about UGT1A1 and the effect that it has on both irinotecan and sestizimab. From my experience, is actually sometimes profound, especially if patient is homozygote for allele star 28 or star 6. But other than that, if a heterozygote patient, usually require dose reduction, but we usually do that in perhaps a second or third cycle, depends on the patient reaction. We just watch them very closely. So I'm just gonna swift through this because this, as I said, this was written for a different lecture. But there is significant evidence that to suggest the test is better to be done for this type of patient. And from my clinical experience, especially with this patient, it's quite profound. I have another patient who's actually currently just finishing with his sestizimab, and she was heterozygote, and we reduced the dose at the outset by 25%. And she managed actually to go into complete remission, despite the fact she was actually advanced metastatic breast cancer with bone mets, and she had a complete response. Unbelievable. But even the dose reduction with 25% dose reduction did not actually impact her outcome because she still actually have a full treatment response. And that give you quite a significant idea or important thoughts that to actually think about your patient, whether the dose reduction will impair the effect or not. Obviously guided by the guidelines, but also use your clinical experience to judge where you're heading with these type of patients, because the guidelines is still coming short. Another case, which this is just a provocative thoughts. This patient we haven't done any PGX for her at the outset, but she, another breast cancer, she was a neoadjuvant, and she's supposed to be actually respond and go into remission, or the plan was curative intent, that's what I'm trying to say. And she had just a doublet of docetaxel and carboplatin with trastuzumab because she was HER2 positive. One cycle, she came with severe diarrhea. That severe diarrhea turned to be typhlitis, and 24 hours later, she had a major infarct to her bowel and upper GI and liver, and within 48 hours, she passed away. But before she passed away, I came with an idea to actually request gently from her husband to have a buccal swab, which we did, and we sent it over. And unfortunately, she was actually a poor metabolizer for the CYP3A5, and it's known to actually affect taxanes. But again, the guidelines does not come that clear for us to order this prior dosing patients. So those two provocative cases, just for your thoughts. So I'm moving now to the Australian healthcare system. So in Australia, we do have publicly funded healthcare. A majority of our healthcare is publicly funded. But unlike the UK has an NHS, which has covered everything from A to Z in England. But for us here, we have something called Medicare, and the Medicare majorly cover all public sectors, and also we have a subsidiary of Medicare called Pharmaceutical Benefit Scheme, which cover the medication at a reduced cost to patients. So all the expensive MAPs and chemotherapeutic agent, those are all, maximum the patient will be costed around $31 per prescription, which is really trivial. These MAPs usually goes, for example, pembrolizumab is around $8,000 a dose. If we go 6 weekly, even $16,000 a dose. So you can imagine how significantly subsidized treatment. We also have a private health insurance. It's income tested, and so everybody above a certain threshold of income per year are required to actually have also their private health insurance. That can help you get into private hospitals rather than just government hospital, and also will give you some reduction in the cost of certain tests, and also in certain privately funded medications that's not covered under the pharmaceutical benefit scheme or outside of indications. We do have for low-income Australians, they get some concession healthcare card, and that's give them a very significantly subsidized. So instead of $31, they pay $7.70 per medication. So that's just to give you a brief where we at with how the Australian system get funded. We have this is all federal, but we also have our state government, which is mainly the public sector, where I work. So the public health care, it's the construction of tertiary and general and secondary hospitals across the state. So why is pharmacogenomics is actually important? As you know, this is very quickly to just refresh your understanding. So we have two major aspects: efficacy and toxicity. So and basically because each one of us respond to medication differently. So again, this is a very well-used slide that everybody uses, I guess. And we have the people who actually benefit from the treatment in blue, and people who have a partial benefit in green, while non-responsive they are in gray, and the people who had adverse effect maybe a lower percentage, but that's quite significant. So instead of one size fits all, it's no longer accepted to treat people in that fashion anymore, because of now our knowledge and our advances in understanding about this all type of medications. And so we always learn in school, in the undergrad level, is that we have inter-individual variation in PKBD, characteristics of all the almost all medications, and that's due to polymorphism or germline mutations. So from that perspective, that's in the olden books of people aged like myself, you will actually perhaps come across that inter-individual variations, and there is no explanation to that. But we no longer accept something like that anymore, because we know the disease variation is actually due to our genetics. And people from different ethnic background, they may express certain ability to metabolize and clear certain drugs different than the others. And whether that's due to oxidative enzymes, which is what we call it the CYP450, or the conjugative enzymes, which all either likely intracellular, but it also can be in different part of the body. Just a brief, obviously, we know what the polymorphism is involved, whether it's a single nucleotide polymorphism or variances, or within the insertion or deletion, we call it endo, or complete structure variation of the actual gene, whether it's a more duplication or more insertion, or deficiency of a certain clone of that gene. And as we all know, we led by the CIVIC group, which is the implementation consortium, and that's across the globe. Everybody actually follows CIVIC group. CIVIC interact with the Pharmacogenomics, which is basically concerning a little bit of gene curation, but also some guidelines. So the Pharmacogenomics is a mixed bag, but they have a more progressive acumen than CIVIC, I believe. So, and they interact with BGRN as well as with CIVIC. But the PharmVar is the main organization that actually curate the genes and actually have that constant work or ongoing work, I guess, to add more to the actual library of genes. And that's utilized by all different parties. So what's the situation of the uptake of pharmacogenomics in Australia? We currently we don't have anything that's globally being recognized, with the exception of something called TMT and not T15, because a reasonable number of or percentage of population of Asian descent or background, they likely don't have any issue with their TMT, but there is a similar enzyme in the Asian population mandate or likely, which is called NOT-T15. So they might actually show a deficiency of the NOT-T15 or dysfunction, which means if we're testing for captoprene or 6-captoprene or azathioprine, we look at, in Asian population, we look at the two, the TMT and the NOT-T15. So that's across the whole spectrum. The abacavir or abacavir has been actually originated from here by Simon Malal, one of our aides or immunologist. He was actually back in the early 2000, actually found the impact of the particular enzyme abacavir, which is become a mandatory testing for PBS criteria or prescription. So that has to be done prior the clinician will able to actually prescribe abacavir. However, those are the only thing that we actually currently across all the states, across all jurisdiction, we're actually implementing. What happened to the other like the CIP 450 or the different pharmacogenomic panels or DPYD, GT1A1 and others? It's very ad hoc. We do have 3 centers within Victoria, which is Melbourne mainly, and another 3 group, actually not centers, I mean group, in New South Wales or Sydney, 2 in Queensland or Brisbane, and 3 groups in South Australia. And South Australia, we have one of, he is considered as the father of pharmacogenomics in Australia, which is Professor Andrew, gosh, I forgot his surname. I'll remember him. Somogyi. So Professor Andrew Somogyi is one of the very pioneer early on in Australia since the early 2000, and he's built a lot of research around that. However, because he's a researcher, he doesn't apply to clinical settings. So it's mainly focused on research rather than implementation. In WA, we've got our group and also a couple of other groups, which are mainly mental health. But we, still trying to actually revive or get things uptaken here a bit more in WA. Most of the labs that does the pharmacogenomic panels or testing are private. It's led by Sonic Genomics, which is belong to Clinipath, we call them, Australian Clinical Laboratories, MyDNI, which is one of the best laboratory in the country that does this type of testing. Public labs like Pathwest here in WA, Health Pathology in New South Wales, also proceeding with certain development within their laboratories. Recently, the Royal College of Pathology in Australia of Australia has actually lodged a position statement, which I was privileged to actually be a reviewer on that statement. It was finished last year and been published early this year. We do have an interest group within the Australian Society of Clinical Pharmacologists and Toxicologists, and that's BGX6. Each state has a representative. I present WA, and other states have other representatives. But we gathered once a year within the conference settings, a day prior to the conference, and that's mainly full day dedicated for PGX presentation, research, implementation, all sort of different discussion between the group. We have a significant focus on mental health across the different states, so it seems to be more interesting to general practitioners and some of the psychiatric or psychiatrists within the sphere. Since 2017, I got into the research with that MISC project, and I presented a couple of posters in 2019, and that's, I think, triggered people to follow suit and start actually looking into cancer care. I was not aware that there is much movement in cancer care prior to that time. I could be wrong, but from my recollection, there was a couple of research done in South Australia around tamoxifen and the 6-PD, and then some other research as well around the same thing. So from that perspective, I don't believe that there was much movement in cancer care until 2019 within Australia, of course. As I said, it's ad hoc. It's individual clinician and individual institution that are actually implementing PGXs. Mental health is major. Cardiology and transplant has moved in the last couple of years, especially on tacrolimus and clopidogrel. So they start to do some work around that as well. In cancer care, it's the model of care mainly through outpatient pharmacy clinics that actually, see the patient, recommend the testing, and so forth. So that's a general overlook. The statement, hopefully that will work. I'll just show you the RCPI statement. Can you see it?
You may need to reshare the window. We see your presentation.
Okay. Sorry. Yeah. That's it. Yeah. Yeah.
Yep.
Okay. So basically, the RCPI has put this position statement, which is very much similar to CPIC. So they have recommended, which is the recommended one group of medication, those ones. So you can see mercaptopurine, thiaguanine, voriconazole, 5-fluorouracil, capecitabine, and abacavir, allopurinol, and carbamazepine. They also moved to that as well. All right, so those are the recommended ones. Oops. Yeah, and then you have the consider one, which is quite a few, and no consensus. It's mainly significant number of psychiatric medicine. And you can notice here tacrolimus, but I guess there is more evidence nowadays. This is almost 12 months ago, so tacrolimus have more evidence to suggest that it should move to actually at least suggested or recommended even. So that's the current status. So I have to just stop sharing this one and I'll move back to the my presentation. Here we are. Okay, so that's where we're at, but it doesn't differ much about than Civic, so it's very similar to Civic in that sense. All right, so moving on from that, the Australian Precision Cancer Care, I'm just going to give you an overview about that. And so what do we do in that space? We have what we talked about when we talked briefly about pharmacogenomics, we mentioned about efficacy as well as toxicity. So this is the part of efficacy where we actually look precisely where the mutation, the somatic mutation mainly, within the cancer. And if for those who actually know what molecular tumor boards are, it's a group of clinicians that sits where they do what we call it next generation sequencing to the actual patient samples, and then out of that, the machine itself actually match the mutation to a particular molecule or drug. And then we enroll patient out of this, that we make recommendations, and we enroll patient to clinical trials if that molecule is not available. It's mainly available in clinical trial, for example. So that's actually across the board. In WA here, we meet every week, once a week, and we discuss about 15 patients across the state. So we have only one molecular tumor board within Western Australia, and we have 15 patients that we discuss. And those patients coming from all over the hospitals, different hospitals, not just one. So we meet at 4:30 to 5:30, 1 hour meeting, and we discuss. Obviously, it's the reports are all prepared by the scientists and geneticists and looked at by the bioinformaticians, and then the recommendation is being written. So the clinician sits and we discuss it. We have a pathologist or head of pathology, head of oncology, head of hematology, as well as few scientists and geneticists and bioinformaticians, and myself. So that's what we do. So from the other side, the PGXs we do now, we implemented here in WI since 2020, which is within Rockingham General Hospital, where I actually work. However, Peter Mac has implemented since 2021, and their operation is massive. So from us to them, that we consider very tiny. while Peter Mac actually now have clinics. They run clinics, dedicated clinics. And then we have the Royal Children's Hospital, who are started also to, not implementing, but they are running a study for implementation. So they haven't fully implemented as an ongoing, regular day-to-day practice. So talking about the model of care, I'm going to just briefly mention what is the model of care. So as we said, the pharmacy, it has a cancer-led clinic, or cancer care-led clinic, that's what I meant. While in Peter Mac have a dedicated DPYD clinic and dedicated UGT1A1 clinic. And the reason that they put it in that fashion, because the number of patients is quite significantly higher. So if for those who knows, Peter Mac is one of the largest cancer centers in the Southern Hemisphere. So it's massive operation. And that's why it's worth to do it in that fashion, because they have pharmacists who mainly dedicated to do nothing but DPYD, testing and interpretation, and other pharmacists use UGT1A1. While that's actually in coinciding with the TMT and not T15. However, they don't have a dedicated clinics for that, for those. And those in leukemias and things like this, and mainly in pediatric rather than in adults, which is the Royal Melbourne or Royal Children's Hospital in Melbourne, which is RCC. So from us here, we actually have the cancer-led clinic, the room that I'm sitting here, this clinic see patients every day, and we do, if the patient require testing, we do suggest the testing to the clinician, and we can actually sign the form on behalf of the clinician, take the swab ourselves, and send it to the lab. And some of those tests are covered within the healthcare system, and the others are not, and the patient can opt to pay, or we give them the option if they want to go and test, yes. And if it's costly, maybe $160 for the test or whatever, and that's one single test, not a panel. And then if they opted yes, we do the test. If they said no, I don't want to cost myself any money, obviously we won't force them to do so. So that's where we're at at Rockingham. Royal Children's Hospital, they actually do running a clinical trial, and they have 4 sites. One of them is PCH, which happened to also, for me, working there a couple of days. And they're not looking at the chemotherapy or cancer therapy PGXs, but they're looking at the supportive medication PGXs. Just because all the protocols and dose reduction, those amendments are run under the oncology, the cancer, the Children Cancer Oncology Group, or COG, which is an international group. So they can't really reduce doses or suggest without approval. So they opted to do it for supportive meds for the time being, until things getting a little bit better. But unfortunately, they have all the facilities, the testing and interpretation and everything is in Melbourne. All the other sites are just participating, reporting back to them with the required number of cases. So they're recruiting and sending their samples over to Melbourne to be tested, and then the results will come back to us at PCH. Okay, so what we actually focus on. So this is what we focus on, the 3 in pink or light red. The fibrin and TMT, not T15, fluoropyrimidine and DPYD, irinotecan and UGT1A1. Tamoxifen, it's usually not done, but there is a movement to actually carry on instead of wasting the time using tamoxifen, and it's not as effective. And the rest underneath here is what the Royal Children's Hospital will be focusing on, especially tacrolimus and allopurinol and rasparinase and all sorts of different things for managing transplants and so forth. As we know, there's a lot of research happening in the world, and this is very sketchy evidence to suggest that this very important sort of different enzyme gene pair, which might be actually influencing our practice in the very near future. Just again, provocative thought. I'll leave it there for you to think about what you think. We'll see what you think. As you know, this has also been the CIPIC group has recommended all of those ones that we're talking about has been having guidelines with the exception of GGT1A1. However, JKB has already published some guidelines around irinotecan, but not the cystizumab. Just going to skip this. Just a comparison between panel and single gene testing. We tend to do single gene testing here, unfortunately, with the exception of SIPs. But I think that's the way we try to negotiate actually development panel. And one of the things that Royal Children's Hospital are doing and actually devise a panel, so that when hopefully once they finish the study, their panel might be available to others. So I did develop a panel as well myself, but it hasn't seen the light yet. So here we just give you a bit more about what we do at Rockingham. So what we do in our clinic is that we see the patient. We see about 6 to 8 patients a day. Sometimes a little bit more, sometimes never less actually. But we focus on the first cycle is significant education to the patient. If the patient is have some like 5-fluorouracilcapcitabine or irinotecan cystizumab, we do preemptive testing in this scenario, and we offer the patient to be tested prior coming in for treatment. So that's what happen before they come for treatment. When they're coming for cycle 1, we do the education on the chair while they are on the chair, and then we follow up with them and how they're progressing with the treatment. We monitor any side effects that's developing, and we advise accordingly how to manage it and how a strategy to prevent it as well if it hasn't happened yet, and to ensure that the patient is well looked after. And if we have any issues, we refer, sometimes actually ask them to present to EJ if required. Again, I'm the only pharmacist on the molecular tumor board, so that's part of Rockingham work that I do. We do also something called adaptive dosing. I'm not sure if people are actually aware about that, but this is part of the precision cancer care. So while we don't use busulfan here, but we do busulfan at PCH for transplant induction. So if basically we do the first dose according to body surface area, then after that we measure the AUC and then advise about the amendment dosing. But from a Rockingham perspective, we do it for cisplatin, sometimes carboplatin, sometimes oxaliplatin in certain type of patient with, patient with renal dialysis or peritoneal dialysis, renally impaired, or patient with extreme weights, whether very low weight or very high weight. So we do the adaptive dosing for platinum compounds, which is something that I also saw in my travel in Marseille. We do have dedicated mucositis clinic within the clinic for chemorad patient. They get referred to myself, and then I look after them and manage them really well. So basically, then we also look after the immunotherapy management and side effects profile. And recently, the last couple of years, we've been using a biphasic monoclonal antibody, things like epcoritamab or blinatumomab. And then those have ICANS and CRS management, so we're quite involved in that. As for the education, currently at UWI, we do have about 10 hours contact time around pharmacogenomics. So that's split it in that fashion. We have 2 lectures, 3 hours, and then we have 2 tutorials, and that's all delivered by myself and Professor Phil Persham, one of our lead pharmacologists. And then we have student project. We choose the project for the students, and the small projects all about pharmacogenomics. And then we have also 2 student seminars. What happened with the seminars, we choose particular gene drug pairs, and that the student look further in to understand what's happening with this type of interaction. And then they report back, they read the evidence, and they report back in a seminar. And the student versus students, so a group of students present their gene drug pair, and the other student criticize them, and we actually just moderate between them. So it's a student-mediated sort of forum. Other universities have a similar structure, but I think is less because we up our hours in the last couple of years from 1 to 2 hours per year to 10 hours, which is 5 times quite significant improvement in that regards. The current research, I have the MISC study, which is the high-dose methotrexate study. This is a synopsis, just for your records, but we basically devised a genomic model to be able to test methotrexate polymorphism within the patient. So this is a cell line model that we devised in a lab, and basically validated that model in the lab. The human arm, we have 60 patient DNA sample retrospectively. So we genotyped the MTHFR and SLC19A1 and look at those genotyping and also review the clinical notes, what happened to those patients. So because it's retrospective, we don't have any involvement of what happened to the patient. I would rather actually try to see what's the side effects, how fast they clear the methotrexate, because we have levels and all the sort of things in the clinical notes. So we can actually link it to those polymorphisms, try to establish if there is any relationship. Okay, and we also do through Monolix, that's spelled wrong here, MONOLIX. Monolix is a modeling program or software that we put the data through and devised a model already for that mathematical model utilizing the data. The fellowship, which was 2022, I visited 18 centers across the US and Europe, and then came back to Australia, tried to actually bring people around what we saw in that trip, and building basically a system that is more versatile, more comprehensive. But it's taken a long time due to the fact, obviously, there is resistance, but it's also the resources are very important, and the funding is very scarce. So that's basically the hurdles in that fashion. Again, this is for record your information. Some pictures throughout my fellowship. Liverpool, Marseille. This is Leiden, and also the cards from the Dutch pharmacogenomic group. And this is the Levine Cancer Center, and that's Howard McLeod in St. George and Cincinnati. So that's basically but I went in the US and Florida as well, but I didn't have any Florida picture at this stage. But yeah, so yeah, improve the education levels. We have already implemented in clinical settings. Was awarded the Chair Fellowship and an Innovation Award back in 2022. And yeah, we're trying now to put together a working group within WI, which is might be early next year. So that's where we are in WI here, in Australia in general. And yeah, that's it.
Well, thank you. That was a lot of different components you covered, pharmacogenomics. I guess I don't know if it's a good thing or a bad thing, but it seems like we all face the same challenges. It doesn't matter what part of the globe you're in. From education to implementation to just the barriers that we face in healthcare and implementing anything new. So I have just a couple questions because there's so much to cover. I have so many questions personally for you. So we'll definitely talk some more. But, I thought it was really interesting you do education on cycle 1 for patients in your clinic and offer them the option of the testing. I'm just curious, and I think our listeners are as well. I guess what are some of the things you hear from the patients as you're educating them, and what percentage of patients proceed with testing versus saying no, I'm good, I don't want to get tested? I'm just so curious to hear about that percentage.
It's a very good question. Thanks for asking that question. Basically, I would perhaps say maybe my perception is 9 out of 10 will accept the testing. Because we explain why the test is important. So when we actually approach them, they already been told by their clinicians. So we have very supportive clinical colleagues or doctors who actually pro pharmacogenomics, and hence they breach that point to them at the outset when they're coming in for a planned visit. So the visit for the planning of the therapy, then they pass them to us after they see them, and then I'll actually talk to them, tell them the test, what it actually do, how we actually interpret the results, and I don't actually shy away by talking to them. Okay, you might be 80% certain that this is what it can do for you. However, we cannot be 100% certain. So at the outset, I'm clear what to expect from the test. So then nothing unrealistic expectation, basically. And then the cost as well. So the cost, if it's covered within the state government pathology, then there is no cost to them. Okay, so then that's not an issue, because none of the patient will refuse to be tested for that. I haven't seen anyone that actually worries. They do have questions. We still tell them what's going to happen to my DNA after the test is done, and how are you going to actually manage it, because some of them are perhaps mistaken that the DNA is a risk that they be cloned or something like that, or anyhow. But we clear the mud for them. We make it very clear for them that this is DNA that will be saved in a certain closed environment and will be destroyed within certain number of months or years according to the protocol of the testing, and we be very, very open with them. However, when it comes, if the patient has to pay for it, usually it's around between $160 and $250. So if one test is $160, for couple of tests is about $250. So that's Australian dollars. So it's still not that significant cost, to be honest with you, because the cancer care costs a lot of money. So that's very trivial in that regard. But because the patient have to pay for it, that's where the issue is. Especially our cohort here at south of the river in WA, it is a lower socioeconomic group or people, and that make it a little bit harder. So we might have one, as I said, 1 in 10 or maybe maximum 2 in 10 that maybe not refusing the test, but they cannot afford the test. So from that perspective, they decline. We now currently actually in the process of application for funding to fund the patient. So then there will be no disparity between patients just because the patient cannot afford it. And we go through something called briefing notes. We revise it. We already submitted to the head of the healthcare system, which is the DJ or the Director General. Goes through hierarchy until it get approved and then get filtered down to us. So we were awaiting a response on that, hopefully a positive one. So that's basically. Did that answer your question, Sharmeen?
Yeah, that answers it. And I have yep, it does.
Yeah,
Thank you for that. It's, and I'm glad to hear that there is some work being done to make sure that there's no disparities, because, it would be so unfortunate somebody wanting a test but they just can't afford it. And the like you said, it's trivial to the full cancer care, and the benefits from it could be a lot more because it can improve outcomes or even at least minimize toxicities. So I'm just going to go, there's several questions here. I know I want to be respectful of your time, but I just also want to ask these questions.
No, that's all right.
Okay. What key metrics should we be tracking to assess the long-term impact of pharmacogenomics integration on patient outcomes in cancer care?
That's a very, very deep question. I'm glad somebody asked it. So I think the key metrics is that you actually need to follow patients. If you can have some database that you actually record what the patient have done. We do have something we utilize here is called the RedCap, and we actually instill the data. So basically, when the patient agrees, the patient will be uniquely identified with a code, and then basically what type of cancer, again, that's a different code, and then we put through the testing, the drug itself, and the test that you carried, and the dosing that you are recommended after the test results. Then that give you ability to track those patients to see how they respond, and how did they, especially if we actually amend the dosing. And because amending the dosing can have a negative impact on the cancer outcome, which we don't want to actually get to. So it's very important that we actually keep track with this type of patient. And from that perspective, also keep track with the dosing. We don't want to underdose patients, but at the same time, we want to actually utilize the proper dosing for those patients. For example, I'm going to give you a quick example. You may come across it through CPIC calls. I'm aware that the CPIC recommendation about capecitabine, it goes from about 50% to 25%. It's quite significant when you have a reduced some of the variant in DPYD, and the phenotyping is around 1.5 or something like that. It's not recommended to reduce. It's recommended to reduce up to 50%, and that's a big reduction for us. I will never actually go 50% on these patients because again, you may compromise the outcome. So you would go perhaps initially at 25% dose reduction, and then see if the patient actually coping. If there is no side effects has actually shown within the following 2 or 3 cycles, then you're good to go. You carry on 25% dose reduction. If there is, then you have a room to move down. But I wouldn't do it at the outset at 50%, definitely.
Okay.
If the
Yeah,
phenotyping is less than that, then that's a different issue.
yeah. Yeah, and that's the balance you have to strike, right, between just kind of preemptively reducing the dose and making sure the patient's getting an adequate exposure versus the toxicity. And do you combine that with, then doing pharmacogenomics plus some monitoring of levels where it can be done with medications?
Yes, we sometimes do if the patient is difficult to actually navigate. So some of the patient, as I said, for example, in the platinum setup, again, we don't have anything to test, not yet, at least nothing actually solid to be tested for platinum compound. So what we do is we actually, for the first dose, we dose it according to the recommendations. Let's say, for example, patient with a certain renal function, and we reduce the dose according to that suggestion. But at the same time, we do the monitoring. So we do 5 levels the same day, so 5 points measurements, sometimes 6 even, and then we build the model, and then we see what's the outcome of that, and then adjust the dosing according to that model. So if the model is okay, then we don't touch the dose, we leave it as it is. If it's not, then it will tell me what sort of level I should be aiming for.
Yeah, that's great.
So,
That's very interesting. I have another question regarding the panel tests that you mentioned that you have developed. Is that based on the known polymorphism in the literature?
I'm not sure I understand that. It's
So
based, and the panel is actually about 12 to 13 genes, and I have about 24, I think, from memory, 28 alleles that I put together. And I did it actually because I was applying for funding. So we want to actually fund panel development. So we want to actually develop the panel, fund it so that it can be validated, because the main cost of panel development is actually actual validation. The validations through certain companies, international companies, that may actually run up to $100,000 or maybe even more. So once you validate it, then it's actually available, and then we can actually utilize it quite legitimately, and would be quite robust from that perspective.
Yeah. And along the same lines, are you seeing, I guess, I think this is what the question is, but I'll go ahead and ask how it's written. In your PGX research, are the reported polymorphisms in the literature similar to those that you're seeing in Australia? I imagined, the frequency of the alleles and which kind of what's sort of in the population that you're seeing in Australia.
Well, it's hard to tell because different literature or different studies are done on certain ethnic groups. So you can't really, and one of the things that we struggle with, all the DPYD sort of testing and research is mainly done in Caucasian, and hence a lot of non-Caucasian, they still will utilize 5-fluorouracil and DPYD, which means even when we test these patients, it may be all good, no issues with the genotyping, but at the same time, the patient cannot actually tolerate it, or tolerate the capecitabine or 5-fluorouracil. What I saw in Marseille, which is something we actually currently trying to adopt here, it's the phenotype testing, which is through measuring uracil and the 2H uracil ratio. So that's a very simple chemical test. It's not a genotyping test. The uracil level is actually linked to the activity of the DPYD. So you measure the activity rather than measuring the actual gene itself, or map the gene itself. And from that perspective, you can tell how much likely that the patient like. So that give us a little bit more versatile data, because it's not depending on the actual genotyping, which is the point we test the 5 points. Even the most tests that done is 5-point mutations, which is all majority of them are Caucasian. In Australia, we have a mixed population. So I have a significant percentage of Asian population, Aboriginal population, Caucasian population, and people from all walks of life. So different part of the world. So we've got a big group of people that has mixed genetics, and those people interact as well. So meaningly, their ancestors and different than they are now, and their kids will be different than they are. So it's stuff like that's make it really hard to navigate. From my perspective, because the availability of the test is the most important. If it's not available, that we can't really do much to navigate this difficult, I guess, mixed genetics, I would say. So I don't think it's any difference than the US. I think the similar situation in the US and Canada. Maybe Europe is different slightly, because mainly, Caucasian, but for our population, it's quite mixed.
Yeah. Well, the good news is that we're all moving in the right direction, where we're trying to expand it in all parts of the world. So we have a more representative data in the literature. I have a question from someone in Ireland. Would you mind sharing what you think? Would you mind sharing, you think that the lack of standardized algorithms incorporating pharmacogenomics data impact clinical adoption and implementation of PGX testing, particularly for drugs with narrow therapeutic indices like warfarin?
That's a very tough question, I guess. Look, I think I'm aware that there is some algorithm out there that companies developed and utilize, and it's all commercially motivated, I guess, algorithm to actually maybe help people, but at the same time it's not being shared on a scale that have, I guess, scrutiny, proper scrutiny and peer review. And I think every company has a different algorithm. We have one here in WA that they develop algorithm here as well. They're called GeneS, and they have their algorithm mainly in mental health. However, they develop it. No one actually know how they develop it. They don't share, because it's, again, sharing that idea, meaningly they lose their IP, and if they lose their IP, that's their trade gone. So from that perspective, where to go? I mean, I think it's important that any algorithm like this is peer reviewed and is actually scrutinized, because you actually build a clinical decision based on that. So how I know that this is actually the right thing to do? When I went to Cincinnati, they also have some sort of algorithm that they utilize, and it looks reasonable and good. But again, I can't fully judge it or support it or not support it. So I guess the algorithm, there is few out there. Which one is the right one? Which one is better? I can't really tell you that. I'm sorry. I don't use any algorithm myself. I use my clinical judgment.
Yeah, I mean, that's what it comes down to. We're not, I think, I would say we're not at a stage where we can just kind of blindly just take an algorithm and move forward. You always have to have your clinical judgment, because I think, there's something to be said about the human component of making those clinical assessments, right? So I know we're over our time. I can keep going.
I'm not bothered So you can keep going. I'm not bothered.
Okay, all right. I just want to make sure. I know people are
That's-
they're very interested in your answers because I have everybody still online listening in, so that's good. And I have a lot more questions, but we'll try to, kind of select a couple more, and then the rest what we can do is share with you, and maybe we can
Sure.
answer via email. Let's see. There's so somebody has a question about first, they said, Dr. Thank you for your insightful presentation. Couple questions regarding preemptive testing as an approach to facilitate implementation of PGX care. The first question is, in palliative care for cancer patients, are they also subjected to PGX, or is it just the curative, I guess, neoadjuvant treatment? And then this person asking the question is interested in ZEB1 and CRC. Are they implemented to identify and treat patients with ZEB1 expressions or molecular markers? I'm not sure if you're.
I'm not aware about that one, so I don't use it, and I haven't tested or used it. I'm not sure. Maybe he can enlighten me to tell me where it's used. But from a palliative care perspective, and let me state this, and I know this might be controversial, but I don't think we should actually use patient prognosis, I guess, to discriminate against them. I don't believe that is right. From a healthcare perspective, I don't think that is right. Would the patient make the decision? I think they are capable of making that decision, or their relative will make that decision for them. But at the same time, I'm gonna actually, again, this is provocative thoughts for everyone online. These patients may have palliative care by definition 1 year to live, okay, or almost. If you read all the certain references or books or whatever, some even go 6 months or 1 month or whatever. But that's the time that they have left. Wouldn't you maximize the time with a good quality of life, or for a small price? So I think it is worth it, because if it's me, I would test for it, because if I'm using a medication, say for example painkillers, I'm using a painkiller, morphine, and I've the PRR1 or whatever it is, that not functioning right, and I'm struggling with my analgesia, whatever. Then I would rather test and knowing exactly what analgesia that I need to use or what the doses is, so I get it right quickly, so that I'm comfortable for whatever left in my life. Wouldn't you think in that fashion? I would. I know I would, especially that I interact with a lot of patients in that settings, and that time of their life is perhaps become most important, because that's all they have left. Maximize it so they can enjoy it with the loved ones. The loved ones don't see them distressed or in pain or struggling. It's very important. It's actually more important in my view. So it's not only for adjuvant or curative intent. I don't think so. No.
Yeah,
That's my opinion.
Yeah, that's great. So I think we'll leave the audience at that, so they can think some more about this topic. If your questions weren't answered, we'll try to respond to you via email, and we'll send those over to you, Dr. Zayed. Any kind of parting thoughts? Any advice for? We have students. We have kind of a variety of people.
I apologize if I actually give you a very quick or delve into different areas very quickly, but I just wanted to put things in perspective for people, mainly that how important PGX is and how we're still coming short with a lot of patients, evidenced by those 2 cases that I mentioned very quickly. And but again, hurdles are the same across the globe, and it's only if we work together, I think we can get where we needed to be. One again provocative thoughts before I finish is that I think preemptive testing is the way to go, and that preemptive testing at the time of diagnosis, not the time when we actually decide to do the treatment. So from my perspective, ideally, that we have what we call a cancer pharmacogenomics panel that we test from the time that the patient diagnosed with cancer, whether we will use this or not, it doesn't matter. We have the information. When we get to use it, it's readily available, whether it's in palliative care or in adjuvant settings or neoadjuvant settings, whatever it is, it doesn't really matter because we have the panel. It's done and dusted, one cost, one panel, multiple genes, done. And then we can utilize this information as we require. I think that's the way to go for future.
Yep. I think I would say personally, I'm in agreement with that, and hopefully that's the way we're moving. So appreciate your time and very insightful presentation. Like I said, we will, send over all other questions if you want, want to be reached out to. But if anybody wants to reach out to Dr. Ziad directly, I'm sure he's okay.
Yeah, I don't mind.
He would be okay
absolutely.
with you reaching out via maybe LinkedIn,
or send me a message, and I'll send you my emails or whatever. Yeah,
sounds good.
And thanks, Zina, for the invitation, and thanks to everyone.
Thank you for being with us today, and thank you, Sharmeen, for the great moderation.
Thanks, Sharmeen. Thanks for your effort and
for back attendees.
Coordination.
Yeah, thank you.
Okay.
Cheers.
Bye-bye.
Have a good day.
Bye. Thank you. Have a good night.
It's very late night, actually.
Goodbye.
All right. Bye-bye.
Bye.